good day, and many thanks to the D-Foot International and for the opportunities for presenting this on behalf of the Ergo Medical, looking at a global analysis of the cost effectiveness of TLC and NOSF. I think I'll probably be preaching to the converted, or if I say that the DFU is a massive and growing global burden. It's a burden not just to developing countries, but it's already a burden on the developed countries as well, even where it might be assumed that there are good resources for this. On a global expenditure, diabetes is expected to have a global expenditure of nearly or over 900 billion. Looking at the contribution from DFU alone, in the US is estimated to be around 38 million, in Canada 38 billion, sorry, and in Canada 546 million, and it's nearly double that for the UK, and in a similar way nearly 600 million in France. But I think despite all this investment or financial burden, diabetes, as we all know, will continue to increase as per the IDF atlas and data that is available. And 1 in 4 of people with diabetes will potentially develop a foot ulcer. The worrying fact is that most of these DFUs will get infected and can result in amputation. And evidently there's over 1 million amputations worldwide per year. And as it usually gets quoted repeatedly, that 85% of these amputations are preventable. And indeed, we all know every 20 seconds someone somewhere around the world is having an amputation due to diabetes complication. So not only is this a morbidity burden, but also a significant mortality or significant impact on life, with the 5-year mortality rate being up to 70%. A mortality rate which we all know is higher than most cancers. So here we go, what can be done? The objective will therefore be to try and reduce the healing time. So the sooner the wounds can be closed, we can then perhaps avoid infection and amputation, and it's only by closing these wounds sooner can we maybe avoid this burden. In 2018, the publication of the Explorer RCT was a significant milestone, i.e. being the first study of its kind to be published in a well-reputable journal, the Lancet of Diabetes and Endocrinology. And as some of you might know, this was a randomized, it's double-blinded, and a double-blinded controlled, and it was stratified in 2 parallel groups with 240 patients, and these were done in centers across Europe, which were international renowned centers of excellence for looking after patients with diabetes, foot ulceration. So of the 2 groups, both of them receiving standard of care, the active group having the TLC and NOSF, and the control group having the neutral dressing, and in subsequent slides, treatment group depicted in red and the control group in gray. And these looked at the complete ulcer healing at 20 weeks follow-up. And indeed, in the treatment, in the TLC and NOSF group, there was 48% healing and 30% in the control group, giving nearly 60% more patients were healed. And as already said, this was a stratified trial. So looking at patients' outcome based on the wound duration at treatment initiation. The data also shows that the earlier the treatment was initiated, the percentage also healing was much higher. On average, the mean also duration for this cohort was nearly 6 to 7 months. So these were difficult to heal wounds and chronic wounds. But looking at the stratification, the earlier the treatment was started, the better the outcome. So in summary, from the Explorer study, treating with the TLC-NOSF always delivered a better healing outcome, irrespective of time when it was started. But the sooner the treatment is started, or the sooner the treatment was initiated, the higher the efficacy. Subsequently, since the publication of the study, there has been a few health economic models that has been based around these results. And what I'll try and do in the next few minutes is to look at 5 of the published models in UK, France, Germany, China, and Canada. But there have been other publications as well, so an abstract in value in health, and 2 other projects in Czech Republic, Australia, and Spain, which these have all been done unilaterally or independent of the of Ergo Medical. It's been mainly clinician led. So starting with the UK the UK results, or the UK model, all the models were based on the Markov model. In the UK, it looked at the direct cost, and then we used the perspective, or the outcomes as depicted or shown from the National Diabetes Foot Care Audit, which all centers in the UK that are, or in England and Wales, that are looking after patients with foot disease are supposed to report to. In this Markov study, the outcomes from the Explorer study was extrapolated to show what will possibly happen over a 1-year period, i.e. patients' proportions are depicted depending on different states, i.e. having an open wound pre-amputation, or closed pre-amputation, or healing with an amputation, and each time the proportion can be deceased or die accordingly. Looking at the results from the UK study, having treatment with the TLC-NOSF provided a better quality adjusted life years, more than the neutral group, and the spending per patient per year, i.e. in the TLC-NOSF, was cheaper to treat with the TLC-NOSF, giving between 300 and 400 per savings per patient per year. As such, the use of the ErgoStart range gave better healing outcomes and saves on treatment costs, reducing the healing time and better quality of life. Looking at the France model, again based on the statutory health insurance in France and the Markov model, this data was extrapolated to show a 1 year, 5 year, and 40 years. As such, it was trying to look at the entire lifespan of the patients, as in they can have ulcer, recurrence of ulcer, or healing and remaining healed. And this was done in 2 scenarios, looking at the ulcers as based on the Explorer study, or looking at the time of initiation of the treatment. And likewise, there was significant savings per patient per year generated with the TLC-NOSF. And looking at all the wounds, there could be a savings of about £3,000. But once again, the sooner the treatment is started, the better the generated savings per patient. And again, it delivers a better quals gained. Most of the expenditure here comes from the hospitalization of patients and nursing care. As such, as we said from the beginning, closing the wounds sooner is what delivers the cost savings. Looking at the German model, Again, here it was extrapolated to 100 weeks. Again, looking at the two scenarios similar to what was done in France. And here, once again, for all the wounds, it was 30% cheaper treating with the TLC-NOSF compared to the neutral dressing. And again, the sooner the treatment is initiated, that generated 43% more or 73% reduction in cost. So again, the sooner the treatment is started, the better the cost savings that can be made. Looking at the China model, this was done for both direct cost and indirect cost, and done for Markov model across eight states in China, and the time duration to wound closure at 20 weeks was extrapolated to 20 weeks. Once again, the same was true for China, and better quality of life gained, and again the cost per patient, it was cheaper, about 1,400 euros cheaper with treating with the TLC and OSF. Looking at the Canada model was similar to the German model, in the sense that this was an extrapolation to 100 weeks of the patient's treatment as well, and again a better quality of life gained, the cost per patient again cheaper, more than 4,000 euros savings per patient if treatment done by the TLC and OSF. So in general, treating with the TLC and OSF was definitely a less expensive. So it's less expensive and more effective. Going from the left to the right is more effective. So in economic terms, it is a dominant strategy, regardless of the country that the treatment is adopted or implemented, regardless of the health model or the reimbursement model of the country. So in conclusion, the evidence supports the case for adopting Ergostat dressing to treat DFU, and although not presented here, similarly for the venous leg ulcers, as per the data or the conclusion from the UK NHS or NICE. And if 25% of people are having the treatment of their DFU with the Ergostat instead of non-interactive dressing, then the NHS stands to save up to 5.4 billion each year. And as we said, this is all time dependent or time critical. And as I said from the beginning, in the Explorer RCT, TLC and OSF dressing have proven to reduce healing time, healing more wounds compared to neutral dressing. And if we're going to try and reduce this cost burden, I think it's about implementing this and early. And on top of the healing outcomes that the Explorer depicts, the 5 cost-effective models in France, UK, Germany, China, and Canada have demonstrated that using it is more cost-effective treatment option compared to neutral dressing, and it does deliver gains in years of ulcer-free life. And the sooner the treatment is initiated, the better the outcomes in terms of clinical benefits for the patient, and in terms of the savings generated by the health system, again irrespective of the country or the type of reimbursement system. And as such, the NICE guidelines has recommended the use of the Ergostat as a first-line treatment, both for leg ulcers and for diabetic foot ulcer patients. Thank you.